Good evening, beloved colleagues. It's sharp 5 p.m. and I want to wish all of us a very happy new year. This is the very first in our series of academic programs for this biennium of the Nigerian Society of Anesthetists. And we have on the call the national president, and we have a few consultants on the call and a lot of residents. I'm happy to see all of you here, and I'm hoping that a lot more of us are going to join. Thank you for sparing the time to come. You will notice that in the past 2 years, we've been doing our webinars on Sundays, and we feel that as part of work-life balance, we should allow our colleagues to spend their weekends with families and friends. And so we are trying to see how we can use the weekdays for our educational programs. So going forward, we are going to be having the residence academic series on the first and third Tuesdays of the month. And we are going to be having a bi-monthly webinar for the General House, that is the NSA webinar. We hope that we are going to have very interesting and very educative topics that we can all relate with. And this being the first in our resident academic series, we have today on the call Dr. Nkoyo Onyenri, who is going to be presenting to us. She is a senior registrar in anesthesia in Department of Anesthesia, Intensive Care and Pain Medicine, University of Calabar Teaching Hospital. And we are also going to have today Dr. Abasim Fonudo, who is also a senior registrar in anesthesia in University of Uyo Teaching Hospital. And we are going to have them, we are going to have Dr. Basim Fon moderate going forward. As I round up this, I want to welcome the president. I believe at the end, the president will say a word or two. So without much ado, I want to hand over to the moderator, Dr. Abasim Fon Udo. I hope that we are going to have a very useful academic feast. Once again, you're all welcome and Happy New Year.
Thank you very much, Ma. Thank you very much, the President-elect and the Chairman of the Education Committee of the Nigerian Society of Anesthesiologists. I want to bring a very warm welcome to everyone and Happy New Year. Glad to have every one of us here. Please, we'll be having I'm Dr. Abasim Fonudo, the Senior Registrar from University of Uyo Teaching Hospital, who will be moderating today. And we want to set a few ground rules before we start. Please, let's keep our microphones muted unless we are speaking so that we can ensure a smooth session. And also, it will be best for us to rename our devices. So kindly rename your devices to reflect your full name as attendance will be taken. For the session, we'll have our structure as follows: 5 minutes for our opening formalities, 30 minutes will be the presentation by our speaker, and we'll be using 15 minutes to do our question and answer session, 10 minutes for our closing remarks / engagements, and also for our question and answer segment, we should type them. And also we should feel free to write our questions as the presentation is ongoing so that we can ask questions and seek clarifications. Our seniors are already here waiting to see how we respond to the presentation. So let's sit back, let's relax, and we hope that we will benefit much from this enriching session. So without much ado, I would hand over the floor to the presenter to kick us going. Thank you.
Good evening, professors, consultants, senior registrars, and well-wishers. Please, can you hear me?
Yes, we can hear you. Please go ahead.
Yes,
I can hear you.
Thank you very much. I am presenting enteral feeding in the ICU, and I'm using the following outline. At the end of this presentation, the objective is to highlight the importance of enteral feeding in the critically ill patients. I'll try to discuss a few indications and contraindications. I'll explore feeding methods and the different formulas available in our environment. I also address challenges and complications, and then review 1 or 2 journals and best practices. I'll use the following outline. As a way of introduction, critically ill patients are prone to having malnutrition because of the high catabolic state in which they present with. There's usually increased breakdown of muscles and protein and muscles, leading to loss of weight in the first week of critical illness. It's even worse in the ones that are chronically ill for a long period of time before presentation. That is why nutritional support aims to alter the clinical course of critical illness, and it usually improves the outcome of critical illness by provision of calories, protein, electrolyte, vitamins, minerals, and trace elements. I also want to point out that protein is the most important of all the classes of food among the components of the nutritional formulas that we are expected to provide this group of patients. And I have already said that because there's increased breakdown of muscles and muscle protein, that's why it's pertinent that we replace accordingly. Nutritional support is considered an integral part of critical care, and this feeding can either be in the form of enteral nutrition, meaning feeding through the gut, or parenteral nutrition, meaning feeding through the veins, which could either be through the central line or the peripheral parenteral nutrition, or as a combination of both, depending on the indication available. So the primary goal is to supply patients with macronutrients are the carbohydrates, the lipids, the protein, and then micronutrients are the vitamins, the trace elements, and other supplements to support the macronutrients. And all of this put together aim to produce energy production and to sustain enzymatic function. Since there's a lot of increase in mitochondrial activity, it's pertinent to support this group of patients to assist them combat the current clinical state. The other secondary goal of nutritional support is to modulate immune function, and this will further improve wound healing for the post-operative group of patients who are in our ICUs, also reduce infection rates, and then combat the hyperinflammatory reactions that are ongoing. There are different types of formulas specific to that. So the ICU population generally is very heterogenic, meaning it comprises, depending on the category of ICU, it comprises of different group of patients, ranging from the elderly to the pediatric age group, ranging from the post-operative patients who were just acutely ill and just went through a prolonged surgery, to the very ill ones, to the very also to the very ill ones who have been chronically ill for a long period of time and have become cachexic. Also, we also find some patients with malignancies who have originally been starving for a long period of time and their body is already in a ketotic state. So it's important that nutritional intervention should be chosen with care and be tailored towards the type of patient we are dealing with. So what is the importance of enteral nutrition? Enteral nutrition, according to the ESPAN and the ASPAN guidelines, they have advocated that enteral nutrition is more favorable as compared to parenteral nutrition, and all efforts should be targeted at instituting enteral nutrition as the first choice of feeding for this group of patients. And that's because, one, it maintains gut integrity. Two, it reduces infection risk by preserving the gut barrier, and is also cost effective as compared to parenteral nutrition. Three, it also provides essential nutrients for recovery and healing. I want to also explain briefly here too. In our environment, we have the option of using our staple diets to provide blenderized meals for this patient, as opposed to buying parenteral formulas, which could be as high as, some have had 80 to 300,000, depending on the category of feed. So we should try to use our locally stable diet to working closely with the dietitian, turn them into semi-solid liquids and to help our patients. That picture down there is just an example of an enteral formula. So I want to talk about the essential nutrients. I'll be very brief with this. We all know that energy is already derived from the three classes of food. I had mentioned that. So in order of percentages, carbohydrate usually makes up to 50 to 60% of the general food components, then protein and the lipids. But for critically ill patients, it's important that they have specific formulas or of requirements of each class of protein. So it's been said that carbohydrate produces up to about 4.1 kilocalories per gram in a normal diet. Likewise, protein, but lipid provides up to about double of that, up to 9.4 kilocalories per gram of energy. The previous slides just tried to highlight the chemical composition of each of those macronutrients. For protein, which I would like to delve on, because of we are talking about the critically ill patient, it different nitrogen. The presence of nitrogen in the carbon-carbon compound is what differentiates protein from the carbohydrates and fats. So major source of this endogenous protein is the muscle. So usually in a starvation state, when the body no longer gets enough from the exogenous, that's from outside, it results to muscle breakdown. And that is why upon admission in the ICU, within 2-3 weeks, the patient starts losing weight if replacement of calories are not adequate, because the body ends up mobilizing the muscles to undergo gluconeogenesis in order to keep up with the high catabolic state of the patient. So this table simply highlights the nutritional requirements in a healthy 70 kg adult. We usually estimate that an ideal weight for a male, no matter how much the person, based on height and BMI, between 70 to 75 kg, and then females a little less than that. So that's the formula of a 24-hour requirement of an adult. An adult, a critically ill patient, will require 25 to 35 kilocalories. However, some sources have said that critically ill patients should require up to 35 to 40, depending on, for instance, for the septic patients, for the trauma patients, for the burns patients, we require a little higher than that. So we should take into cognizance of the type of patient we are calculating the meal for. Then for protein is usually seen as a very key component of their meals, and that is why it is calculated differently and to be ensured that it is met up in a 24-hour basis. The patient must receive 0.8 to 1.5 grams per kilogram per day. Like I said, the septic, the burns, and the trauma patient will require slightly higher. Now for fluid is being calculated that patient will usually require 1 ml per kilocalories per day of water. So for instance, if the calculation ended up as, let's say, 2,000 kilocalories per day for a normal adult, it means the patient will require same meal of free water accordingly. Also, as part of the nutritional requirement are electrolytes, vitamins, and trace elements, which means that all these patients must be continually receiving some form of supplementation. In our environment, we commonly give histamine, the Astifas, and other generally acceptable supplements in order to combat this electrolytemia from happening, which is a common complication. So I included this slide because just before we have identified the critically ill patient and we have decided that we should commence this enteral feed within 24 to 48 hours according to our Spain guidelines. Now, we have to do that based on calculation, based on the weight, and it has standard formulas. There are standard calculators online, which we could easily impute patient age, height in centimeters, and it will give us the exact ideal body weight. But this is just like a side note to remind us that taking into cognizance the weight of a patient is important. If the patient is overweight, it's important that we use the ideal body weight, which should usually be between 70 to 75 and not more than 100 in most cases. And then if the patient is already underweight, we should use the actual body weight. So Also, there are other options. There are different school of thoughts, lean body mass, depending on what need be. But the point is there are calculators, standard calculators online where you input patient's details and then it will give you the estimated body weight or ideal body weight to be used. So on average, we have decided that, for instance, this is a 70 kg critically ill male that has met all the indications for enteral feedings. How do we calculate how much formula is needed? So most enteral formulas will come as a pre-packed formula with the exact kilocalories per meal of which it contains. Let me show you an example. For instance, isosauce, that's a type of standard formula. So it's usually important that we calculate the estimated 24 hours requirement for instance, for a 70 kg male who requires enteral feed, 1.5 times, if we're using 1.5, for instance, or 1, depending on, it means 1 time is 25 kilocalories per kg per day. That is the 24 hours requirement. So this patient is going to require 25 times 70 kg, which will mean the kilocalories per day for that patient. Also, you have to include the protein that patient will require, which will be 1.5 grams of protein times 70, which amounts to this. And then the free water the patient requires, which will amount to this. Now, you now go ahead to choose what brand of formula do I give this patient. Am I going to give a standard formula? For standard formulas, they're already written on them. For instance, this isosauce already has 1.5 kilocalories per meal to be given. That means this patient, the meals to be given over 24 hours will be the total body requirement divided by 1.5. That will give you the meals in 24 hours. Now, the product of that would now be divided per hour, depending on how we choose to space it. If we are doing hourly via an infusion pump, or we want to do in aliquots for 4 hourly, but it's important to carefully make this calculation and clearly state it on the treatment charts for the nurses. Otherwise, we will be underfeeding the patients, as occurs in most cases. Now, having said this, in our environment, what if we're not able to get to Nestle to buy this? There are options of using a stable diet if we can arrange with the nutritionists in our hospitals who would blend our diets and tell us the exact kilocalories per meal of that of what that meal contains, and that could be given to the patient. These are other examples of blenderized diets, but not in our environment, which I brought this up to highlight that majority of them usually have their how many meals is there and how many kilocalories it contains. And majority would usually come in between 1 to 2 kilocalories per meal. And then also, some of them also state how many grams of protein is contained therein. So if after calculation of the 24 hours requirements, if it means that, for instance, giving 1,750 mils of isosauce did not completely cover the protein requirements of the patient, it's important that we should supplement the protein for that patient by either arranging with the dietitian for either boiled eggs or other protein sources in order to make sure we reach this. Otherwise, patients will start losing weight by the 2nd or 3rd week. So what are the indications for some of these nutritional support? Most patients that are in ICU within 24 to 48 hours should begin enteral nutrition. Is being overemphasized. Also, majority of, if the patient is hemodynamically stable, even if it's on vasopressor, the trend of events if the patient is on double dose vasopressor, is not an absolute contraindication not to start enteral feed, as far as the airways have been protected. by invasive mechanical ventilation. Also, I saw a source that stated that bowel sounds are a poor indicator of small bowel activity. So the usual way of assessing that this patient can tolerate enteral feeds is to start what we call trophic or trickle feeds, or trophic or trickle feeding. That is giving little aliquots and estimating the gastric residual volume before the next feed. That will usually tell us if the patient is able to tolerate or if we should step up or step down. Now, this flow chart is simply telling us about the brief physiology of critical illness as it occurs. Usually in the early period, day 1, day 2, there's a high increase of catabolism, and it goes upwards. It goes upwards and then comes down towards the late phase. So that is why it's important to supplement their diet around this period, usually within 24 to 48 hours. So this flow chart is simply showing the effects of nutrition on nutritional status on inflammation. So usually when there's increased inflammation, there's release of cytokines, and this release of cytokines usually decreases appetite and overall nutrient intake, which will further cause starvation, and then there's going to be stimulation of gluconeogenesis. There's going to be lipolysis and other breakdown of glycogen stores. Also, because of the stress, there's increased cortisol production, which will further cause decreased insulin resistance and decreased glucose uptake by tissues. All of them usually result in a state of starvation, which will still end up having increase in catabolism and protein energy malnutrition later on. So now we have seen the patient. The patient meets indications to start. There are no gastric or absorption issues, things that will prevent absorption issues in the intestinal tract. We have commenced. How are we going to? We're supposed to assess this patient for clinical evidence of nutrition. Even after we commence, we're supposed to monitor the progress, and that can be done with the use of the subjective global assessment, which involves history taking, physical examination taking, and the use of some laboratory investigations. So this group of patients that I highlighted in these slides should be nutritionally assessed in order to choose an appropriate feeding regimen. So patients who were already coming in with a negative balance. What I mean is patients who were already malnourished before coming to ICU must be nutritionally assessed and commenced immediately. A patient who are already chronically ill, I had already mentioned malignancy, patients who already have some form of organ dysfunction, or even the people undergoing treatment. For instance, those on chemotherapy, there's a lot of lysis, they need to be urgently supplemented. Patients who are septic, trauma, burns, they already have very high catabolic rates. Even patients who presented for emergency surgeries, there's going to be, in the previous chart, I mentioned there's increased cortisol. All of that will result to some form of high catabolic state in the body, and then this group of patients must be supplemented with their nutrition. Elderly group of patients, usually aging is associated with physiological anorexia and some form of chronic illness, which will in turn affect nutritional status. So this is the subjective global assessment I was talking about, in which it's a tool that is easily used to assess or carry out nutritional assessment in the ICU. It's pretty easy. History can be taken from the caregivers, weight change, whether it is over 6 months or acute over 2 weeks, any changes in appetite. If the patient has been having any gastrointestinal symptoms like anorexia, vomiting, diarrhea, it could tell you that this patient may already be having electrolyte deficiency before commencement, and that should form the basis of some judgment in terms of instituting the doses and how to start. For if there was some form of functional impairment, it could give us an idea that this patient was really ill at home. Physical examination, we are going to assess for loss of subcutaneous fat, looking at what I have highlighted. If there's evidence of muscle wasting, if patient is already edematous, it simply shows that this patient may likely have hypoalbuminemia, which could also be hypoalbuminuria, which could also be a form of protein energy malnutrition, or if there's presence of ascites, it could also indicate that. So there are other methods, subjective and objective methods of assessing patients in ICU, which will involve anthropometric measurements. I have already mentioned that biological tests, which we can easily get access to, muscle function testing too. You can ask the patient hand grip strength. How strong can the patient hold? You can be an indication of if this patient is really already working at a deficit or not. The history I've already mentioned, and then the body composition and other ancillary investigations. So what are some of these routes? What are the sites to administer this enteral feeds? In as much as it's the first line of feeding for critically ill patients who cannot feed by mouth, there are different routes in which we can administer this feed. It could either be through a nasogastric tube, a nasoduodenal tube, nasojejunal tube, or even for patients who require very long standing feeding, the percutaneous gastrostomy tube is also an option. Although the nasoduodenal, the nasojejunal, and the jejunostomy are technically technical to insert, and sometimes will require radiological guidance as opposed to the general nasal tube feeding, which we commonly do. So that should be performed using a lubricated fine bore tube to avoid ulceration, and it could either be orogastric or nasogastric. But we should also note that there's increased frequency of bleeding during insertion for nasogastric, especially when not lubricated. So, and then there are contraindications to nasal intubation for nasogastric tube insertion is relatively contraindicated in patients with fractured base of skull. So if patient presents RTA patient, we should rule out that this patient does not have basal skull fracture, and before we commence that. So this tube can also give us a guide to check our gastric residual volumes, which could be used to assess tolerance to our enteral feeds. I had already mentioned that the other routes will usually require radiological assistance to insert. So up to 47 patients in ICU will suffer from gastrointestinal motility problem. Like I mentioned, most of these ill patients, they are sedentary, so they are not active. So we will not expect everything to be as optimum as it should be. So it's important that before the next feed, that we insist that the nurses check that the patient is able to tolerate feeding. So according to American Society of Parenteral and Enteral Nutrition, ASPEN, who have been quoting since, gastric residual volume, when they are between 200 to 500 mils, and with the absence of other indicators for intolerance of feeding, enteral feeding should not be stopped. That means if you have more than 500 mils, that is when we should hold on with enteral feeding. That's just what they are trying to say. So there are other options at which we can tackle the motility problems in ICU with the use of our D2 antagonism, metoclopramide, that we know at 10 to 20 milligrams intravenously every 6 hours. And some sources have highlighted that erythromycin can also be used to decrease gastric paresis. That's gastric paresis. I just simply mean that's paralysis of the gut. So in other options of choosing these enteral feeds, we should try to choose the standard formulas, which are almost isotonic, so that there will not be some form of osmotic diarrhea, as just like we do with IV fluids. So it's the same thing. We try to choose. That's why most the ASPEN and the ESPEN, they recommend, the journal I have put at my last slide for further reading, they were arguing that the standard formulas are safer for majority of the group of patients, irrespective of what their underlying illness is. I've already talked about the content of how much kilocalories per meal most of this formulation comes. But I also want to talk about that there are different types of enteral formulations available, and they all vary in their osmolality, the electrolyte composition, the mineral and the vitamin contents. But most of them are lactose and gluten-free. And they usually meet up the daily recommended intake of healthy adults. So we have the standard polymeric formulas, which comprises of the carbohydrates, the protein, and the lipid in the ratio as applicable. Most of them between 60 to 70% contains water, and then the other components in the ratio of 1:2:1. That's carbohydrates, the protein, and the lipids. Then there are other variants for specific group of patients. For instance, we have the elemental and semi-elemental formulas. We have the standard formulas that have been upgraded with fibers, which will help patients who are having diarrhea in the ICU. We have disease-specific or specialized formulas for patients who have renal failure. For the renal failure patients, their protein contents have been reduced because of their underlying clinical state. For the patients who have liver or hepatic encephalopathy, most of their feeds have been reduced such that there's one that they call pulmonary, the ones with the COPD patients, they have a special type of formula in which their lipid content has been dropped such that the carbon dioxide that is being formed during the energy release is reduced. So different categories of patients have different types of formulas, but it all depends. But what Aspen and Spain are clamoring for, they are saying that except it is highly necessary, that most times the standard formulas should be able to meet up with majority of patients. There are also immune modulating formulas, which aside from the macronutrients contents, they are enriched with specific nutrients like the arginine, glutamine, and the omega-3 fatty acids, which are particularly beneficial for the huge inflammatory processes that are ongoing for the ill patients. We also have, I've already mentioned, fiber supplemented formulas, high protein formulas. It all depends on the patient's clinical state. So what are the important considerations? There are so many formulas, there are so many options. We have options to feed these patients. What are the things we should consider? We have calculated the weight. We now know the number of meals in 24 hours to give. How do we go around making this very difficult choice? The patient's clinical condition. We should assess the severity of illness. Is it an acute or a chronic illness? Do I start low dose or just give the patient the normal volume calculated? It all depends on how sick these patients are. So the general consensus is the more ill a patient is, the lower we should go and titrate upwards. If there's presence of organ dysfunction, same rule of thumb applies. If there's some form of gastrointestinal tolerance, same rule applies. After calculating the patient's 24-hour calorie and protein requirements intake, we should also consider the route. How easy is it? Is this patient going to require a long-term feeding option? Then NG tube would not suffice for this patient. We should now keep in view insertion of the percutaneous endoscopic gastrostomy tube with discussion with the surgeons. So those are the important considerations we should put in place. And then there should also be not just starting the enteral feeds, there should be a form of monitoring the progress by use of the anthropometric measurements. I'll talk about it when I'm talking about the journal. So sometimes while starting, we need to monitor our albumin levels. Is whatever intervention that is being undertaken in the ICU needs to be monitored in terms of progress. Are we winning? If not winning, what do we change? So those are the intricacies that should be addressed. So this is just an example of some variants of the standard formulas. Some are more peptide rich, like the peptamine and peptide rich. Like this one is a standard formula that is augmented with fiber and the likes. It all depends on what the patient needs. So there's no process without complications like we know in medicine. So we have gastrointestinal, we have metabolic complications. We also have mechanical complications that could arise. Now, for the gastrointestinal complications, like I said, there could be diarrhea, especially in the chronically ill patients who have not been feeding for long, and then suddenly you introduce something to the gut. There's going to be increased gastric motility, which will result to diarrhea, affecting up to 60% of these patients. And that is why at that point, consideration of addition of fiber to their diet would be necessary. There's also room to give probiotics in addition to their meals. If the patient is not tolerating well, there could be regurgitation of the feeds into the respiratory tract. There could also be nausea, vomiting, constipation because some of them might be on opioids, which is a common cause of which is a common cause of decreased gastrointestinal motility, resulting to constipation. The ones who have malignancies, especially patients with abdominal pain, it's likewise to a healthy adult who have been fasting for hours, and then without drinking water, you just start eating, you could have sudden abdominal pain. So it's the same thing. There could also be bloating. What are the mechanical complications I mentioned? There could be tube displacement, especially in the nasogastric tube. Nasogastric tube, especially if it was not confirmed with radiological confirmation. There could also be clogging. There are sometimes the NG tube can be clogged and it needs to be reinserted. I've mentioned there's an important metabolic complication I'm going to talk about later on, the refeeding syndrome. If patient regurgitates into the airway, there could be aspiration pneumonitis. So that I had mentioned that in cases of diarrhea, we should enrich the feeds with fiber. So I'll just skip this. So these are the prevention strategies. So it's not enough. We know the complication now. So how do we prevent this from happening in our patient? So for aspiration, we should ensure that we state it clearly to the nurses that during feeding, head of bed should be elevated to at least 30 degrees. And then the feeding tube should always be confirmed radiologically. That's the standard. Then for diarrhea, we should, if it's antibiotics, it must be important to exclude all infective cause of the diarrhea. Then if it's not infectious, yes? Yes? Hello? If there is not an infection that is causing the diarrhea, we remove the precipitating drugs such as antibiotics, and then we exclude the common organism which is associated with antibiotics causing diarrhea, and then fiber would be added. Then for the refeeding syndrome, we should monitor as soon as enteral feeding is commenced. We should monitor electrolyte abnormalities and replace accordingly. That is why there must be a baseline EUCR and other serum potassium, phosphate, and magnesium levels before starting, especially in the ones that have been ill for long. So for the dehydrated patients, I had mentioned that we do not just calculate kilocalories in 24 hours. We must include the protein calculation and also the free water to be given to these patients. So for enteral feeds alone will not necessarily meet the daily water requirements. So supplemental enteral water should be given, which is more advocated for than intravenous fluid in order to prevent fluid overload. So this is just what are the current trends. This was adapted from a single et al., where different group of patients versus the type or how fast we should institute enteral nutrition. So for the first three group of patients, as highlighted, should receive low dose enteral nutrition and titrated upwards. And then this other group of patients below are the ones in which early enteral nutrition should be performed. Is well stated, and that if you check that table, it's almost comprises of majority of our patients that present to ICU. I mentioned earlier on, especially for the calorie dense formulas, that some contain omega-3 fatty acids. So I wanted to just mention
round up in 2 minutes, please.
Okay. So the role of omega-3 fatty acids, it helps to combat inflammation. That's just what that slide is talking about. So this journal they simply did a prospective study to find out how best it is to assess malnutrition in critically ill patients. So their conclusion was that anthropometric measurements were better predictors of nutritional outcome than biochemical tests. So that is simply to say, treat the patient and not the test results. So I want to talk about refeeding syndrome because it's very, very important. Usually patients, a patient is not supposed to become more ill after starting to feed. So we should watch out for this, especially in those group of patients I highlighted earlier on. So patients who resume nutritional intake after a long period of starvation are prone to this. So what happens simply here is, institution of feeding causes insulin levels to rise. And what insulin does at the cellular level, it pushes, just as it's pushing glucose into the cell, it also pushes phosphate and magnesium and potassium, resulting in low levels of these minerals, because this patient already has depleted stores from the prolonged starvation. So sudden feeding will cause the increase in insulin levels, which will push most of them into the cells, resulting in sudden collapse. Also, thiamine deficiency can also occur, and we know that low levels of those electrolytes can precipitate sudden cardiac arrhythmias and respiratory failure. So that is why it's very important to watch out for those very ill patients, especially monitor their electrolytes and replace accordingly. Replacement of their supplements cannot be overemphasized, because most times is the common presentations of these electrolytemias are arrhythmias and sudden death in the ICU. So these are the group of patients that we should have a high index of suspicion of having refeeding syndrome and be on the lookout for, and then the prevention strategies should be put in place. So in conclusion, we should know that critical illness is a highly catabolic state. So both under and overfeeding should be avoided. In addition to energy balance, we should pay attention to the other aspects of it, the protein and the micronutrient administration. So in summary, we should know that it's important that, and we should know that we can use our stable diet to give our patients in combination with the nutritionist. We can calculate the exact kilocalories per meals. Our own staple diets can be given to our patients under our watch. We should watch out for refeeding syndrome and prevent them. We should also not forget to supplement free water and the micronutrients and other forms of electrolytes. Thank you very much. Please, further reading should be taken. Further reading of this journal. This journal is very rich and tries to argue about the different types of enteral formulas and which to use, and the drawbacks of the other disease-specific formulas. Thank you very much for listening.
Thank you very much, Dr. Nkoyo, for a very wonderful presentation. So we have Dr. Abubakar Bala, consultant intensivist from the Abubakar Tafawa Balewa University Teaching Hospital in Bauchi, and Professor Elizabeth Mwafso, who will be responding to our questions, our comments. So we'll open the floor now for questions, and then we would listen to what our trainers have to add to us. So the floor is open for our questions. Also, I will also be reading some of the questions from the chat. There are questions already from the chat. I will be taking some of the questions also from the chat. So I want to see if we have physical questions first before I start reading the questions from the chat. There's a question here from the chat. Thank you very much, Ma, for the presentation. Could you kindly expatiate on the calculation of daily requirements in kilocalories versus the meals for the—
Please, sir, you're not loud. I can barely hear you, sir.
Okay. Could you kindly expatiate on the calculation of the daily requirements in kilocalories versus the meals for the 70 kg man?
Okay, noted. Should I start answering right away, or I should wait?
Okay, the second question is the time to the commencement of feeding following gastrointestinal surgery like resection and anastomosis. And someone else asked about refeeding syndrome, which You had tidied up towards the ending of the slide. Maybe you could throw more light on it. And finally, our local meals as blended diet, crayfish, eggs, whether raw or boiled, what is your take? So those are the 4 questions on the chat for now.
Okay. So I want to because I was rushing for want of time. So like I said, the normal 24-hour requirements for a 70 kg man is between 25 to 35 kilocalories per day.
Can you be louder, please? We can barely hear you.
Okay. I said, please, can you hear me? Can you hear me now?
Yes, we can.
Yes, loud and clear.
Can hear you.
Okay, thank you. So the kilocalories per day is 25 to 35 kilocalories per day. So for a 70 kg, because critically ill patients require more, we are going to use the upper limit. That is 35 kilocalories times 70. So that will give us 35 times 70. That gives us 2,450 kilocalories that this patient requires in 24 hours. Now, the grams of protein is important to include, and that is 1.5 grams per kg. That's times 70 per day that patient will require. 1.5 times 70 gives that this patient requires 105 grams of protein per day. That's in 24 hours. Now, the third thing you calculate is free water. And free water is calculated as 1 kilocalories, 1 meal per kilocalories per day. That is 1 times 2,450 kilocalories. That's what the patient requires per day. So that means this patient will require 2,450 mils of free water to prevent dehydration per 24 hours. Now, having had that template, what type of meal do we want to give? The meal that we want to give, most of them, depending on our dietitian, would help. Our dietitians will help us with that, but most of them usually come as 1.5 to 2 kilocalories per meal. And some come as either 1 liter or 500 mils, depending on what it is. So what you now do is, the 2,450 kilocalories that this patient requires divided by, let's say the ISO source is 1.2 kilocalories per meal. That's what was written on the packet. So 2,450 divided by 1.2. 1.2 gives 2,450 divided by 1.2 gives us the number of meals. Gives us the number of meals of that particular formula to hang in 24 hours. That is 2,000. We require, for this 70 kg man, requires 2,042 meals of ISO sauce to be given to this man over 24 hours. Loading my whiteboard. Okay, so now, if 2,042 meals is required to be given to this 70 kg man, how much will I give him per hour? It will now be 2,000. Yes? Yes? It will now be 2,042 meals divided by 24. Can you hear me, please? So, divided by 24 hours, that means 85 meals per hour of that meal is supposed to be given to that patient to meet up. Now, the next thing we take into cognizance is how much protein in that formula does it contain. Some of them, like for isosauce, it contains 54 grams per 1,000 meals. It's written on the packet. So whatever is written on the packet, you work with it. That's why it's important to work in conjunction with the dietitians. So if the protein content per 1 liter is not meeting up with the patient's protein daily requirements, we have to supplement with plant and animal protein, like the boiled eggs, which the dietitian will tell us how many grams of protein is contained in one round egg. That is where the mathematics comes in. But our own is to make sure that we are giving the appropriate meal of the blenderized diet per hour, or if we are doing for 4 hourly, we include it with free water. That's just that's just it. It's just math. You calculate the kilocalories in 24 hours and divide it by the kilocalories per meal of whatever formula you have chosen to give the patients, not forgetting to include the free water components, and not also forgetting that protein is very important, not also forgetting that whatever you're giving in the packets, if the daily requirements is more than what is written on the packet, then you have to source exogenous sources of protein to add to that patient's diet. Thank you very much. I don't know if anybody was following.
Yes, we are listening to you. Please, can you move over to the second?
Yes.
Okay, please. The second question was, please, can you remind me?
How long does it take? The time to commencement of feeding following gastrointestinal surgery.
Okay, gastrointestinal surgeries are one of the very few exceptions, because especially resection and anastomosis, you don't want the intestine to suddenly to avoid breakdown of sutures. So you follow the lead of the surgeon in that case. Feed for them. So that's why I can say. So you follow the leads of the surgeons when you cannot be within 24 hours for gastrointestinal surgeries. No. Yes.
Okay, thank you. The next question is refeeding syndrome. Someone asked about it. Another person asked, how do we manage refeeding syndrome? So I think we can take that as one question.
Okay. So like I mentioned, I said refeeding syndrome is just what happens when patients suddenly commences enteral feeds following following prolonged starvation. So sudden surge in insulin levels causes, because there's depletion of total body stores of phosphates, the magnesium, and the potassium. So sudden insulin surge will push the serum levels into the cell, causing overall decreased levels of these electrolytes, which could provoke sudden cardiac arrhythmias. So that's why we need to be on the watch out for. And prevention of that is to start little, slow, and watch. Also, patients who are already deficient should be corrected alongside without waiting. So please, the next question is what?
The next question is your take on the local meals, like blended diet, crayfish, eggs, boiled eggs, raw egg. What is your take on it?
My take is it is better to use what we have to achieve the same thing with our counterparts outside. So I would advise that a standard protocol be brought up in conjunction with the dietitians who know the exact calories per gram of this stable diet and the quantity. So they would come up to tell us, okay, 1 cup of rice, 1 egg, 1 ounce of crayfish will give us so kilocalories. So we know that when we blend and add 400 mils of water, it will give us so kilocalories per meal. So the ICU team need to have that discussion with the dietitians who would convert our staple diet to kilocalories per meals for us. So yes, we should use what we have.
Thank you. The next question is, you said that chronically ill patients should not stay with feeding nasogastric tube for a long time. How long is good to go for feeding gastrotomy to be commenced?
Okay. Okay, so I read somewhere that any patient that will require enteral feeds beyond 2 weeks should be considered for percutaneous gastrostomy insertion, tube insertion. So beyond 14 days. That's why I saw. Maybe my teachers can help me clarify that. Okay, next question, please.
Another question that says, can you explain more on trophic feeds? And also, I want you to add it with this. How do we handle abdominal distension in these patients, especially when bowel sounds are not present?
Okay. I mentioned trophic feeds. So trophic feeds, like I said, this calculation is what we call the goal. That's the goal directed units per meal that we're supposed to give this patient. But there are sometimes that you must not necessarily start giving this patient at 85 meals per hour because you think the patient may not be able to tolerate it. So trophic feeds is administration of these feeds as low as 20 to 30 meals per hour in aliquots in order to prevent this refeeding syndrome and also to prevent gastric motility issues, especially for patients who have been chronically ill for a very long time. So trophic feeds is just administration of little aliquots to the patient while observing. Then, please, I missed the second part of the question.
How do we handle abdominal distension
Okay.
in the patients when bowel sounds are not present?
Okay. So abdominal distension should be investigated. If there's presence of intestinal obstruction, the surgical team should be called to review. But if there's no intestinal obstruction, there's room for use of prokinetic agents like metoclopramide, which I mentioned. So abdominal distension should be further investigated, with inclusion of radiological parameters in order to rule out intestinal obstruction, whether partial or complete. Please, next question.
All right, the next one is, how do you monitor muscle breakdown in critically ill patients? And what is the fear regarding muscle breakdown and how we manage it?
Yes. So how do I handle muscle breakdown? Is that the question?
How do you monitor?
Okay, how do I monitor muscle breakdown?
Yes,
okay, so
critically ill.
Yes. So the end product of muscle breakdown is the creatinine kinase. So in labs that can measure that level, that could be used to monitor. I don't know if we have some of that in my environment, but usually use of anthropometric measurement like the arm circumference, there are things we can do that we have that would tell you that this patient is having some form of muscle breakdown beyond biochemical tests, like the mid-arm circumference, arm thickness, daily measurement of this abdominal gait, and all of those parameters can help us. But specific blood tests can, like creatinine kinase levels, if there's an upward increase, it shows that there's some form of muscle breakdown. Now, what's my fear? If there's a rhabdomyolysis, rhabdomyolysis, it can cause cardiac failure from the end product. So that's my fear, and that should be prevented. And that's why I kept on bringing up prevention strategies instead of treatment. So it's better for us to prevent the muscle breakdown than to wait for it to happen. Our fear is cardiac failure from the rhabdomyolysis that can occur. Creatinine kinase is the specific biochemical test that can be used to monitor that if we have it in our labs. Thank you. Please, next question.
Thank you. In burns patients, what is the percentage increase in feed for them? And when can we commence feeding?
Yes, feeding should be commenced as early as 24 to 48 hours within time of presentation. So their requirements is as high as 2 to 3 times the regular dose. of energy requirements for other group of patients because of the hypercatabolic state that they have. And it should be commenced as early as possible. Any other question?
Thank you very much. I'm afraid that will be the last question. We'll hand over the ground for our trainers to give us their comments and also to teach us. Thank you.
Thank you very much, moderator and presenter, for a very excellent outing. I want to recognize in our presence Professor Eshet, Professor Bolinwaso, our president, Professor Dati. I also want to recognize the consultant moderator, Dr. Bala. I want to very specially recognize someone who has been of great benefit to us here in Africa for our training on critical care. She has been managing the FCCS training for years, and that is Dr. Ann Crawford, all the way from Stanford, California, United States of America. And at point I'm going to let Sinai. I want to also recognize all the way from, I think it's Ziri, I'm not able to pronounce it, has given. Thank you.
Hello? Oh, are
Yes,
you done?
I can hear you, sir.
Okay. Can I come in?
Yes, sir.
Oh, okay. Oh, thank you very much. I'm very delighted that we are able to start this webinar series on a very good note. We thank Nkoyo for this brilliant presentation, which I'm sure has stimulated a lot of interest and comments. We'll never finish, and then we'll go back to read our books and make the best of what you have presented. Before I say any other thing, please, just like the president-elect and the chair of the education committee said, we had some notable people that have joined us from across the globe. Anna Crawford unfortunately had to leave early, but she has listened to much of what was said. Many of you have known her for anchoring the critical care course free on the foundation of critical care. She shared a comment there and also shared a link to a guideline for enteral feeding patients who are on vasopressor. So please take note of that link, which is important. I want to ask Professor Babatunde Oshunaike, who is the president of the Intensive and Critical Care Society of Nigeria, Professor Elizabeth Oboli-Nwaso, a past NSA president, Professor Eshet, if she is still around, and also Papicho Intambre from Zambia. In that order, please, you can unmute and say 1 or 2 words for 1 or 2 minutes. Thank you. Professor Shinaike, if you are around, please. We are in your territory, so I think it's good you say something. Professor Shinaike? Okay, Professor Nwaso, maybe Oshinaike is not around or you will talk later. Please unmute and say something. Thank you.
Hello.
Hello, good evening, distinguished colleagues, ladies and gentlemen, the president, all other protocols duly observed. I just say that this has been an excellent and brilliant presentation. I want to commend Dr. Nkoyo for going very deep into the topic and really making it as practical as possible. My call to all who are listening is the implementation of these guidelines and these recommendations are very important. That is where we sometimes have issues in our practice. It is very important that we bring it home and we make it as practical as possible and implement it on our patients on a daily basis. It should not be a one-off thing. I recommend that every ICU should go sit down on the round table and have a discussion with all the key stakeholders, the nutritionists, and all the people that are involved in feeding of the patients to bring up homegrown and practicable, protocols that can help us to sustain our patients. I have a very extensive experience, both as a practitioner and as a patient relative. And what I can tell you is that it's not really as easy as we are saying it. And sometimes the outcomes are not as good as we will expect. So there still needs a lot to be done to actually make these things operational and practical on a day-to-day basis in our ICUs. So the ball is in all our courts, all the trainers and all the key stakeholders to make it practical and to bring it to be the order of the day, not just a theoretical thing. Thank you all very much for the opportunity.
Thank you very much,
Professor Mohammed.
Okay.
Yeah, sorry, I'm actually driving. I just tried to listen to the presentation.
Okay.
I must say the presenter really did excellently. I'm so impressed with her presentation and the way she answered the questions too. I'm really impressed. I'm sure she doesn't have much of that practical experience, but from what she has read, she has been able to bring it down to us clearly enough. And as Professor also said, it is not that easy as we have heard. Oftentimes, this is a very challenging part of critical care, especially in this part of the world, where we are limited in terms of what we need to use to, monitor the progress of care in these patients, and also the personnel. I must say that the role of the dietitian in the critical care when it comes to nutrition should not be downplayed. And I want to encourage as many of us that we have the opportunity to have this group of professionals in our hospital. We should really make use of them, because sometimes we want to assume the role, or you want us to assume the role of the dietitian. When you have these people in the hospital that can assist you in actually guiding the nutrition of your patient. So that is so important. And to be sincere with you, we can actually bring most of these feeds, we can actually provide them locally. And our patient can actually get the best of nutrition when we involve these professionals to join us in the care of our patients. So I want to say well done, and it's a nice one. Thank you.
Thank you very much, Professor Shinake, President ICCSN. Just as a reminder to our participants, this webinar series is for resident doctors. We want to build their capacity and their confidence And then we have a lot to learn from them, even though they are trainers, but there is always something to learn on a forum like this. Professor Eshiet, if you're still around, please, you can unmute and say something. Okay, otherwise we call, if our friends from East and Central Africa want to say something, I can see Shweka, Mohammed, I can see Papicho in Tambwe. Please unmute if you want to say something before I hand over to the moderator.
This is Papicho in Tambwe. Thank you very much for this wonderful presentation. There was a lot that we've learned. Really appreciate for this opportunity that your society is giving us from this far to learn and to remind ourselves of so many things that we can take for granted. As it was said earlier by the two great professors, nutrition in ICU is the key to the care and the output of the patient. Unfortunately, we always fail to sustain good nutrition because we do not have the means of giving that to our patient. And most of the time, we end up relying to patient's family, bringing what they can also afford. You can give them a list of things to buy, but they are failing to make it. They'll end up giving you what they can afford for you to feed their patient. If we can reach a level where we'll be able to give what is really recommended for our patient, that will be a great thing, and then we'll avoid so many complications that our presenter mentioned earlier on. I would have that little to say, and then I would say again, thank you very much, and we'll be there again for next time.
Thank you very much, Papicho. Any more comments from our friends?
Thank you very much. We are fast running out of time, so I would like our president to say a word or two before.
Okay. Thank you very much. Like I said earlier, I'm really delighted that we are able to start on a good note. This will be sustained and we'll fine-tune as we move along. I know that this presentation discussion is twice a month. Maybe for this month is once because we have another webinar coming, but not the resident series. So we should, now if you notice that there is a departure from our schedule, that we have our webinars on weekends, we try to move away from it so that we can enjoy the weekend, refresh. We are trying to practice workforce well-being. And we know it's not easy, but try to join these webinars, which will be on working days. That is what I have to say. And then I want to implore all of our members to please pay up their dues, get in touch with us to find out the details, the financial secretary, so you can pay your dues, because we need your little contribution to be able to do our activities. Thank you very much.
Okay. Okay, I think the president has closed us. Thank you, Prof.
Yeah, no, I think you can give the closing.
Right.
I mean.
Okay, so thank you very much, everyone. Dr. John Afam here, the trainee representative. Thank you for tuning in. Thank you for being on time for our teachers. Special thanks to our teachers, our professors. Thank you for teaching us. Feel free to log off now. The slides and some further reading materials will be shared on the residents group and on the NSA group. And we are all encouraged, like our teacher said, to incorporate this as part of our practice. So thank you so much. Good evening and have a great week ahead.
Thank you.